Welcome to this keynote address for the MSc in Counselling at Bangor University. My name's Michaela Swales, and I'm delighted to have been asked to speak about the therapeutic relationship in DBT. I'm a professor of clinical psychology at Bangor University, but I've worked for 30 years as a DBT therapist and an accredited supervisor and trainer. And this is a very interesting topic, and it's not something that's talked about much in DBT, and so it's an interesting one to share. I'm not going to spend any time really talking about DBT itself. I'm assuming that people know something about the treatment, but I'm going to focus in on the therapeutic relationship. So this is an outline of what I'm going to talk about. I'm going to talk about the underlying principles that we bring to the therapeutic relationship. I'm then going to talk about the therapeutic style and strategies that we use in the treatment. I'll then talk a little about the therapeutic relationship as an agent of change, and then also about how the relationship is ended. So let's start with the underpinning principles. DBT has some kind of assumptions that we bring to the work that we do. And these are very important in terms of setting the stage about how we would approach the client and therapy. So you'll see here that the first two that we've got here is that the client is doing the best that they can and that they want to improve. And that's our assumption. They've come to us for help, and that's what we assume. And this is a really important counter to some of the kind of views and beliefs that are around in mental health services. Often people who harm themselves frequently, who have impulsive behaviours, who struggle to implement therapeutic suggestions, often they get referred to as being manipulative or not taking responsibility. And these are very damaging assumptions and interpretations for therapists to hold that can make the therapeutic relationship very challenging. Whereas in DBT, we assume that given the client's history, they are doing the best that they can in any given moment. That's why they're coming for treatment. And also that they want to improve. It's just that the problems that they're facing are so significant that actually it's really difficult for them to improve and to know what to do. And also, given the complexity of things, that to have a consistent motivation that goes on over time is really difficult. In dialectical tension with that is the next assumption is that the clients need to do better and try harder if they want to live a life worth living, given how significant the problems that they are. But I think it's it's crucial to say that when we look at this assumption, it is the therapist's responsibility to help the client do better and try harder. So it's our job, our responsibility to understand all of the barriers that get in the way of their motivation, all the barriers that get in the way of them implementing the new strategies that they're being taught in therapy, and to figure out solutions to those to help the client do the things that are required in order to improve the quality of their life. It's always important to remember that the lives of the clients that we treat are currently unbearable as they are being lived. They want to die because their life is currently unbearable. And it's important to remember that. I think when you're in close proximity to somebody who's in unbearable emotional pain and within the intensity that it's experienced, I think one way sometimes of regulating our own emotions is somehow to minimize the extent of the pain and somehow to sort of think that clients aren't serious about dying or about why they want to die. And that's completely antithetical to the view in DBT that clients are trying to die because their life is currently unbearable as it's being lived. And it's our task in the therapy to really address that. Relatedly to that, I'll just leap over to the last one, is that clients haven't caused their problems and yet they have to solve them anyway. That's in a way the challenge and the tragedy of their situation is that they are in this position not for things that they have done necessarily, and yet they still need to solve those problems. And then also finally in this list is clients cannot fail in DBT. If a client goes for chemotherapy for cancer and it's ineffective, we don't say it was the client's fault. And it's the same here in this treatment. This is a life-saving treatment and it's a difficult treatment to do. It's not a perfect treatment, and sometimes it's not administered correctly. And so if the treatment is ineffective, which sometimes it will be, then either that's because it's not a perfect treatment, or it's because that it wasn't implemented correctly. So if your client is ending therapy and it hasn't been effective for them, then it's really important that you're clear with them that this is not because they have failed. Maybe it was not the right time, maybe the two of you were not the right connection, maybe there were contextual factors. And so this really frames how we're thinking about the person. They're in unbearable pain, they're coming to us, in the current moment, they're doing the best they can, they want to improve, and it's our job to really help them out of hell. Now, some assumptions about therapy. I've touched on a couple of them already, but the first is that the most caring thing a therapist can do is to help a person change in ways that bring them closer to their own ultimate goals. And so, as a DBT therapist, when you work with someone, you're going to really start by trying to identify what it is that they want out of their life and commit yourself to helping getting them to that life, or at least part way there. And so that's always our focus. Whatever we're doing, we are always got our eye on the prize of the life worth living that our client wants. To do this, though, the compassion that I've talked about, which is really vital to really see the unbearable pain, be willing to step close in to that pain and to help a person in that situation try and find new ways of being. In addition to that, you also need clarity and precision. If we're going to help our clients, they have very complicated problems. Simplistic solutions will not work. And so we need to really analyze closely emotional, cognitive, body responses to environmental events to really understand them in detail in order to be able to come up with effective solutions. In this endeavour, the therapeutic relationship is a real relationship between equals. Now, some of you might be thinking, well, hang on a minute. Clearly, that can't be the case. There's a huge power differential, and there is. And we have different roles and responsibilities in the relationship. But it is a real relationship in the sense that both parties have a vote about whether they're in this relationship, and both parties bring expertise to the table. And both parties in the discussion of problems or solutions are as likely to hit on a valid solution as each other. Simply being the therapist doesn't mean that you will necessarily come up with the effective solution. This is a joint endeavour. And so, of course, given our power and responsibility as therapists, we have to work hard to make sure that there is this equity between us and that we're really listening and empowering our client to make decisions about their own life. Principles of behaviour, this is linked to as being a real relationship between equal. Principles of behaviour are universal and they affect therapists in just the same way as clients. And so just as we are trying to help our client move towards their ultimate goals, the amount of pain that they're in and the distress that they experience in trying to change their behaviour can be a material factor in pulling therapists away from doing effective things. And so we really need to be awake to that and be aware of all of the factors, not just our client's behaviour, but organisational factors, team factors that impact our capacity to be an effective therapist. I've talked about the fact that we as therapists can fail. We can definitely not do the effective thing, and also we can be doing our best to do the effective thing and somehow fail to understand or grasp some aspect of the problem or not have sufficient resources to be able to do what's necessary. And certainly the therapy can fail. It's not a perfect therapy. We know from randomized trials that around 30 to 40% of people do really well. Another group of about 40, maybe a little bit more, don't change, and then a very small proportion of people, less than 10%, deteriorate. But those groups are very important, people who deteriorate and people who are not changing. This is why one of the reasons, which is why clarity and precision are very important, to really monitor what's happening with our clients and to see if the treatment is effective or not. And if it's not working, to intervene to try to change things. And then, of course, ultimately, if it's not the effective treatment, then another treatment will need to be tried. So these assumptions that we bring about therapy and about the client to the therapy kind of set the stage for the therapeutic relationship. So I'll say a little bit now about strategies and style. You'll know that one of the core strategies of DBT is validation. It's the counterpoint to the problem-solving element of the treatment. And why do we validate in DBT? Well, we do it to restore the historic imbalance of invalidation. Clients have been invalidated from being very young and are continuously invalidated given their responses and their experiences and their contexts. And so we want to validate to restore that historic imbalance. We want to help clients understand the essential validity of their responses. During that raising and invalidating environments, they've ended up understandably with the idea that really they're worthless, useless, and they don't understand anything, and their reactions are completely, there's something wrong with their reactions, there's something wrong with them. And it's certainly true that some of their reactions that they have learned have been unhelpful in interpersonal relationships or in the long term. But many of these ways of reacting were natural responses to the context in which they were in. Sometimes they're natural responses to the context that they're in now, and yet they are still unhelpful. So we're wanting to help our clients understand that their responses are valid and which aspects of their responses are valid and which of the things are that they need to change. And so most often their emotions and their thoughts are highly valid, and yet sometimes the way in which they respond to those is less so. The other reason we validate is to promote the therapeutic relationship. We all want to hang out with people who validate us. And this is one of the reasons why we see people with sometimes complex problems and difficult interpersonal relationships who end up persisting in being in relationships with people who treat them badly. This is because they believe that they are bad themselves, that they are, useless, worthless, hopeless, sometimes even evil. And the thing is, if you're around people who say those things to you, the one thing it gives you is that it validates your perception of reality. And so this is one of the challenges in therapy, is that if we go around just giving positive affirmations to our clients the whole time, they won't want to hang out with us because that doesn't validate their sense of their inner sense of who they are. And of course, we as therapists don't want to be validating inaccurate perceptions that a person is useless and worthless. And this is the dialectical walk that we have to move through the treatment, is to really validate the essential validity of the person and their wisdom, and also be able to talk about the times when actually their behavior is, or their responses are inappropriate to the context or unhelpful in the context, even if in some contexts they are, or in some ways of conceptualizing, appropriate. We validate to smooth the challenging process of change. It's very difficult to change your behaviour, and many of our clients have got multiple things that they need to change to get the life that they want. And it's very difficult to do that if you get no support and encouragement. And validation is a really important component to help people move forward in the process of change, and also to promote and develop their capacity to self-validate, so that when they finish treatment, this is really important, is that to begin with, we might be the only person in their life who's really validating them. We really want them to learn to validate themselves. And also in that process of being more self-validating and changing their inner constructs, then they're more likely to be wanting to be around other people who will do likewise. And it's a mechanism. Sometimes I hear people I've worked with talking about how in the process of treatment that they change their social networks and that they end up spending more time with people who validate them and support them. And this is an important process as part of treatment. What might we validate? Well, any aspect of the client's response that's valid: their behaviour, their cognitions, their emotions, their sensations. And we would want to identify how they are valid. And the thing is, behaviour is complex. So, for example, if a client self-harms in response to extreme shame, how is that behaviour valid? Well, it's behaviour in a number of ways. In terms of past learning, perhaps this is the only strategy that the person has that has been effective in reducing intense shame or other intense emotions. So it makes sense they would keep doing it because it's the only thing that they've got in their repertoire that helps them regulate this emotion. And it makes sense because anyone with a very intense emotion wants to regulate it. That's a perfectly valid thing. And also, if self-harm actually effectively regulates shame, then it's an effective thing to do. So it's valid in that sense. The only problem with it is that it's invalid in other senses. And so it's invalid in the sense that often the relief is short-lived. And so it's like an ineffective strategy in the longer term. And also it means that the client often ends up having to do more self-harm in order to deal with the shame, as opposed to addressing the things that are really eliciting the shame in the first place. So it's invalid in that sense, but it does make perfect sense. And so this is the dance as the DBT therapist, is to take things that sometimes are labelled and experienced as being highly dysfunctional, and to understand those parts that are valid, and to help the client experience those as valid and to understand that they are valid, and at the same time to recognise those aspects that are invalid, that we might say, and the problematic parts, which of course we're going to use all the change strategies in the treatment to address. How we validate is, and of course, validation is in many psychological therapies, not just DBT, and certainly what we would call in DBT the lower levels of validation. So, like being awake to your clients' in session behaviour, what they're saying to you, what their non-verbals are doing, reflecting back to them, reading, mind reading, like what they might be experiencing if they're struggling to articulate. Validating in terms of their past learning, that their behaviour makes sense given their past experiences. But the things that we would spend much more time on in DBT are these last two. So validating in terms of the present. So let me just give you an example. If a client comes into therapy with me and, they are struggling to share things with me, or they say, I have a hard time trusting professionals. A validation in terms of the past might be to say, well, that makes sense to me. Lots of people have let you down in the past, and, professionals haven't followed through with what they've said. And so it makes sense that you're kind of, struggle to trust professionals. This is a validation in terms of the past. This can be very helpful. And it's not as powerful as saying something like, well, it makes sense to me that you're struggling to trust me. You've only just met me. How would you know if I am trustworthy? Yeah. So this is in terms of the present context. And also it's less pathologizing, because it's like a normative thing. You meet someone who's new and you don't know how trustworthy they are. That's something that happens to all of us. It's not about your past history with professionals, or your past history with your family, or all of these things that somehow have, in your mind marked you out as having difficulties. It's just to do with the normal, everyday things. And so we spend a lot of time in DBT validating the intensity of a person's distress, their desire to escape the distress, their natural uncertainty about certain situations, to really validate in terms of the present context and what's normative for human people. This therapeutic relationship between equals. In your shoes, I would have been scared too. That makes sense to me. In other words, it's not because you've got a history of trauma or that. It's because actually it makes sense to me that a person would be afraid in that situation. Yeah. Now, of course, as I've said, there are times when, maybe that wouldn't be a typical human response in a situation. But you can still say it makes sense to me why you would be afraid, because in that context, for example, you believed that your life was in danger. And so it makes sense to me that you were afraid because you believed your life was in danger. Now, maybe their life was not in danger, but they did believe that. And so therefore their fear makes sense. So it's trying to really locate the validity in the present moment, not always in the past. And then also radical genuineness is really about treating your client like you would treat a friend or a family member in that same situation. Now, I'm not in any way saying that your client is not your family member and they are not your friend, and you have a professional role and you must, be mindful of those professional responsibilities. But there are times when you want to give your natural human response. Say your client comes in and tells you that this week they've discovered that their partner is having an affair. You don't in that situation want to respond in the sort of, oh, I'm wondering, what emotions did that bring up for you? The sort of more classic therapeutic response, we might say. Now, how you respond would depend. How would you respond if you heard that from a family member or a friend? You would be, oh my God, that's terrible. How are you coping? How dreadful that they betrayed you in such a way. I mean, you might not say that. You would say whatever will be normal for you. But you want to give your normal human response because you want the client to learn, they have been in raised in environments which have told them their emotions don't make sense. And so if we kind of, do this very reflective sort of response rather than kind of give them a radical, genuine human response, they kind of can be left with that feeling that something again is wrong about their response, that they shouldn't be so devastated, they shouldn't be feeling so betrayed. Um, Now, of course, it needs to depend on the client. You need to know a lot about the situation that they're in and the relationship. You might say something, "Oh, thank God you've been wanting to get rid of him for years," which would be a more irreverent response that we'd come to. Now, of course, you'd still also want to validate the emotional pain too, but there's not a rule about how to do this, but it's about being your radical, your genuine self, your human self, not just your professional self. Now, of course, there are tensions here. It's not a license to say whatever you like, but this honesty and directness is something that clients really value, and often comment on at the end of therapy, that they appreciated that sort of direct response. So this validating style is connected to what we call the reciprocal communication style in DBT. It's warm, it's responsive, and it's genuine, and it directly responds to the client's agenda. And also, as part of it, DBT is a treatment that allows for and specifies the use of self-disclosure under certain circumstances. And those circumstances always got to be in the best interests of the client. So personal self-disclosure might be about your own biographical details and obviously about your professional qualifications and so on, but it might be about things about yourself, and maybe challenges that you faced in your life. And we tend to do these in a sort of modeling self-disclosure way. You don't want to disclose things that are not yet resolved for you, but you do want to be able to share how you've used the skills in your own life to solve problems. So, for example, many of my clients will know that I'm a recovered flight phobic and how I use the treatment to recover from flight phobia, and particularly utilizing exposure. They'll also know about some difficulties that I had with an extended family member over a period of time, where I had to really utilize my interpersonal effectiveness skills to really find a resolution. So you don't want to be disclosing things that are active now and that you haven't solved, but you do want to be willing to share how you have addressed difficulty and used the skills and strategies, only if it's pertinent to the context and you think it would be helpful to your client to hear about that. We also will use self-involving self-disclosures. Now, these are where we give, and it's connected a bit to radical genuineness, but where we would give our responses to the client's behavior. So, for example, it's basically when the client does X, you say, when you do X, I experience Y. So it might be, when the client has harmed themselves again this week, you might say, when I look at the fact that you've harmed yourself again this week, I notice a sense of sadness that we still have not yet been able to help with this problem. Yeah. Or if you've got a client who says repeatedly, I don't know, I don't know, no, I don't know, in response to anything you say. But it seems like it's not a sort of a considered I don't know. It's not a sort of, I really don't know. That's fine. But if they're just saying I don't know very quickly without considering, you might say, when you say I don't know repeatedly like that, my motivation to try and help really goes down. So I'm wondering if we could figure out another way of handling that. And then you would, of course, move into change and trying to understand the function of the I don't know. Maybe the client's extremely dysregulated or afraid, or, and that they're trying to get you to move off a topic, and you need to solve that problem. But it's sort of like a way of just noticing something that's happening, but also indicates your presence and connectedness to the person. And this is the default style of communication in DBT. However, sometimes communication, the relationship is a bit stuck and it's not necessarily going in the direction that you want. And maybe the client is really stuck in a rut. Maybe they are struggling to engage. And sometimes saying something that's a bit offbeat or reframing the client's communication in an orthodox way can be really helpful in getting their attention. A little bit like I said before, if your client comes in and says that, their husband's having an affair and you say, oh, well, you've been wanting to get rid of him for years. Now, that would cause the client to pay attention. Now, then you'd have to move in back to being very validating to deal with the situation. But sometimes that kind of irreverent statement can really get the client's attention. I had a client once who really kept coming into therapy wanting to drop out every week because she didn't like the way some of the male members, this was a young people's group, some of the male members of the group kept looking at her. She was a very striking person in the way that she dressed. She dressed in a very interesting and notable way, which of course was entirely her right. And some of the, particularly the male members of the group, found it very, I guess, attractive and kept looking at her. And she didn't like that, which also made sense given her history. And I tried lots of kind of regular validation because it did make sense to me why she was uncomfortable. But none of that was really helping. She was just kept threatening. And so one day I just kind of said, okay, we've just got to kind of kidnap the male members of the group and kind of lock them up somewhere. What do you think? Now, of course, it's a completely ridiculous suggestion, but because I said it and it kind of caught her attention, she laughed. But then we were able to dig, it made her a little more willing to dig into how we might really solve that problem and deal with her uncomfortableness and also how to handle that situation more effectively for her. We'll also plunge in where angels fear to tread and say things that other people might not say. Be willing to ask those questions that perhaps are very difficult. I had a client who would burn themselves on their genitals, and it's important to ask whether or not they experience sexual arousal during that process. And so, just asking it in a matter of fact way. Sometimes we'll use a confrontational tone. Now, I'm not talking about being really confrontational, but just being very direct, kind of, if the client says, I'm going to kill myself, you might say, I don't want you to do that. That's not a good idea. That won't solve the problem. You might then say, I get you're in a lot of emotional distress and I don't want you to do that. Yeah. So you can use these different, and there are a few other strategies there, which in the interest of time, I won't go into, but this is a counterpoint to this validating, warm, reciprocal style. And in a way, this is the therapeutic relationship in DBT, is that the client can count on you to be warm, supportive, and have their back, and also tell them the truth and get them to do the hard thing. It's like they're on the edge of a crumbling cliff and you have to get them down and they're terrified, but you've got to get them down. And just validating won't help. You're going to have to take them down, and it's going to take a lot of skill, and they're going to have to put feet in front of the other, even when they're terrified of falling. And so they need both of these elements. And so you can see that a bit in this graphic, which indicates the kind of the dialectics of the relationship. It's oriented to change on the one hand. I've not talked a lot about that here, but it is, we do a lot of work on change. But also it's oriented to acceptance, acceptance of where the client is now, acceptance of the difficulty of the task, and yet still wanting to help them change. We have a sort of an unwavering centeredness of like sticking with the difficult thing, getting the person back off the cliff, what they need to come off the cliff. We're not going to let it go. If the client is suicidal, we're not going to let it go. And yet we can be compassionately flexible also, if the client has had a devastating piece of news like their partner's having an affair, then we will be flexible about how we address with things in the session, and we will maybe flex the time for the session or when we'll see them, or maybe we'll see them an extra time that week. And yet we'll also at times be very centered about how we need to stick to the task. And we'll be very nurturing on the one hand and supportive, but also benevolently demanding. We got to get them off the edge of that cliff. We want them down from the cliff, and we want them in the valley of their life of worth living goals to move forward. So we will use the relationship as an agent of therapeutic change. We have a strong relationship and we want to use it. Therapy is an interpersonal transaction. As a therapist, we're trying to shape our client into more functional patterns of behaviour that help them to get towards the life worth living goals that they've specified. That's our task. Yeah, when they come, they tell us that's the place we want to get to. We're like their life travel agent. We have to get them a high-end travel agent who's going to get them all that, has done all the transfers and worked it all out for them, but they still have to do the journey, and we have to help them with that. Um, but in order to do that, because it's a difficult situation, we're going to have to use our interpersonal responses as behavioural contingencies. Um, Primarily, we would use validation. Um, you know, Reflecting, validation can be a powerful reinforcer because, people want to hang around with people who are validating, as I mentioned. So it's very important here to think about the difference between praise and validation. Praise is where we say, like, well done, or you did a great job there, or you're a great person, and the thing is, for many clients, that is more like a punisher, often because praise has been either delivered in a sarcastic way as part of an invalidating environment, or praise has been paired with the withdrawal of support during their therapeutic journey. Um, so it's often a punisher. Whereas validation is much more effective. Saying, this is really hard. I see it's really difficult for you. I can see you're in a lot of emotional pain, and I'm asking you to do something very hard, and I'm pushing you very hard, and it makes sense to me that you want to give up. So rather than saying, oh, you're doing a great job, keeping going when it's so difficult, actually kind of validating actually that you see that it's hard and you want them you get that they want to give up. Anyone will want to give up in this situation. Actually, that can be more of a reinforcer for persistence than praising their effort. You might need to use other interpersonal responses as contingencies. So if you've got a client who, for example, is very talkative but frequently goes off the point and means you're not addressing the main problems, you might have to say, oh, just hang on right there, hang on, can I just stop you? Can I just stop you? I think we're getting lost. When we go off topic, I just get confused about the problem we're trying to solve. So that it's an interpersonal contingency. It's like you're stopping the client. And, for clients who go off on topic, this is something that interferes with their problem solving in their everyday life. So it's not just it's not just a verbal validation, but a functional validation of their problem, but also a little bit more on the matter-of-fact confrontational end, that we would use these responses to try and help shape our clients towards the goals that they have specified. And finally, let's just talk about ending the relationship. So you want to talk about ending right from the beginning. So the DBT programs have a specified length, usually 6 or 12 months, so people know that from the beginning. And from about 2/3 through the length of the program, you want to talk about ending every session. Yeah. During therapy, you want to shape your client's capacity to analyze and solve their own problems in living, and ensure that they've got a range of solutions to their problems, so that they're ready for leaving. And part of that needs to be finding other people who will support and validate them in their endeavor to move on in their life. Yeah. So, of course, for many of our clients, you might have been the first person who really understood them or was really very validating. And so ending the relationship with you is going to be a difficult thing. And often for our clients, they don't have the experience of endings going well. And so it's important in the last third of therapy with those clients to really work on the emotions, the thoughts, the worries that people have about ending, and use all of the strategies of the treatment to help them deal with that, so that they are prepared for the end. And as part of that, you want to orient them to and also be their ex-therapist. This is a special role in DBT. So the ex-therapist can be contacted at any time after therapy is ended on an infrequent basis, but you can be contacted where if the client wants to give you good news, or if they want a bit of coaching about how to move on to some next therapy or some other issue in their life. So you orient them to it, so it's not a frequent thing. I've had contact with many of my clients who come back, who sometimes it's just to tell me that they're getting married, or they've had a baby, or that they've got a new job. Sometimes it's because they've hit a problem. I worked a lot with adolescents, and I would talk with them as we were ending about the fact that sometimes when they have major transitions in their life, like marrying, but particularly having children, if they've had abusive experience themselves, sometimes issues can come back. And so sometimes clients have come to me at those times when they've had babies and issues have popped up for them. And we've just had a little bit of a refresher about what was helpful, and then thought about, did they want to go and try and find a new therapist, or did they feel like they could activate their own support system? So just a bit of consultation. It's not therapy, just a bit of consultation, but to be their ex-therapist. Thank you very much for your attention in this talk. I'm slightly worried I might have gone over my brief in terms of how long I've talked for, but it was good to share these thoughts with you, and I hope you found them useful and informative.